Welcome, everybody. Thank you very much for joining us. Thank you very much for your interest in this in the meeting. Got an absolutely fantastic programme this afternoon, and the topic of our meeting is the infected blood inquiry and its implications. And I just want to make the point to us all that by being in the room, we are the interested people in transfusion. It's a discipline and endeavour that changes people's lives, and we're going to hear about that. It's central to this afternoon that what we do doesn't always change lives in a way that anybody would hope. So our first speaker is going to be Claire Reynolds. She is a senior scientist in the Joint NHS Blood and Transplant UK Health Security Agency Epidemiology Unit. That's a team that's been in place since 1995, and she's going to be drawing on data from 1995 to the present day in her talk. She's led on the surveillance of infection in blood donors since 2007, contributing data to inform donor selection and testing policy reviews. She also set up a process for horizon scanning for emerging infections of relevance to the safety and sufficiency of the UK blood supply, which is reported regularly into the JPAC Standing Advisory Committee on Transfusion and Transmitted Infections since 2007. You can see the title on the screen. I'm going to turn my microphone off, and it's over to you, Claire. Thank you very much for joining us.
Thank you very much, and thank you for inviting me to talk today on behalf of the joint team. So just a quick outline. I feel like I'm here to set the scene in terms of when the UK Blood Services started testing for different infections and how that's changed over time, how it's monitored by our team in order to provide assurance and estimates of what we might miss, alongside observed transfusion transmissions. And then finally, I'll talk quickly about our horizon scanning process. So across the top, we've got when infection screening were first introduced, and these are performed on every donation. So syphilis screening on every donation since the 1940s to the present, right up to recently introduced parvovirus and hepatitis A screening as part of the regulatory requirements for plasma for fractionation, which was introduced in Scotland slightly earlier because they had a local hepatitis A outbreak. So it was very timely that they were able to introduce testing. I'll focus on HIV and hepatitis C in the next slide, but just to say that we've been able to reduce testing for HTLV based on safety data because of leukodepletion. So now first-time donations are tested on a precautionary basis and non-leukodepleted products. While hepatitis E went the other way, we were screening selected donations for specific patient groups who would benefit from screened donations, which was widened out to all donation testing to simplify the process to avoid double inventory for hospitals. And then we have discretionary testing based on donor history along the bottom, where testing is performed based on donors' reported travel and residency, so where they might have been exposed to malaria abroad or West Nile virus while travelling. So let's look at hepatitis C and HIV in more detail. So I've taken these year dates from the IBI report, volume 5, and it just shows that there was a lot of discussion prior to the screening being introduced. So discussion, but no action necessarily. So raised levels of liver enzymes were shown to be linked to hepatitis. So that could have been potentially a proxy test, even though we didn't know specifically it was hepatitis C at that point, but we did know that there was non-A, non-B hepatitis. So we knew there was something. We didn't know exactly what that was, but this could have been a potential test. There were also further discussions in 1983 about anti-Hep B core testing to be used as a surrogate test. And the idea there is that if you've been previously exposed to hepatitis B, you may also be at higher risk for HIV and other hepatitis viruses. But again, that was discussed, but no action was taken. Anti-HIV screening was introduced from October 1985, despite that just being 1 year since HIV was attributed to causing AIDS. It was still months behind other countries. In terms of Hep C, what appeared to happen was that we knew that once hepatitis C was identified, that a screening test would be delivered, but we waited for the better tests to come online. So despite the US introducing antibody screening, we waited to kind of get better tests, and partly that was to avoid discarding too many donations if you have a non-specific test. So we waited for second generation antibody screening. But since then, we've reduced the window period by introducing extra markers. So nucleic acid testing reduces the time between exposure and being able to detect the virus. So detecting the virus directly rather than waiting for your immune response to be able to detect it. So that reduces the window period, and that reduces the residual risk of not being able to detect a positive donation. And that had the greatest effect on hepatitis C, as I'll show later on. So what happened before we introduced screening? So the Infected Blood Inquiry has estimated that up to 100 recipients of blood transfusions were infected with HIV, and around 27,000 recipients were infected with hepatitis C, 22,000 of whom would have become chronically infected. And over 3,000 deaths have been attributed to blood and blood products. So affecting people today, not just in the past. These are data that we hold and continue to collect on blood donation screening. So these are the observed HIV positive blood donations with data from 1985 up to the end of 2024 presented here for the UK. You'll see why I've used this large scale when we look at hepatitis C on the next slide. In 1986, we discovered 20 first-time donors positive for HIV and 33 repeat donors. So these would have been repeat donors newly tested for HIV who we hadn't screened before. Looking at 2024, we found 3 first-time donors positive for HIV and 7 repeat donors with HIV, where we had screened their previous donation and found it to be negative. So HIV is low and variable in the UK donor population, and we've picked up only 8 donations on the NAT screen only since 2002. So that indicates a very, very early infection, and that's what we would be most worried about, because the more early infections we pick up, that increases our residual risk of non-detection. And this is hepatitis C data shown on the same scale. So you can see here that we were picking up hundreds of positive hepatitis C donations once we introduced screening. 518 repeat donors were picked up in 1992. So that was 518 in 1 year alone that we hadn't screened before, and potentially had a positive donation at their prior donation, essentially. Hepatitis C has been declining in both first-time and repeat donors since then, and we've picked up just 16 donations on the NAT screen since 1999. And I chose England data here because you can find this graph, and it's updated annually every year in the UKHSA National Hepatitis C in England report. So nowadays, each year between 0 and 2 repeat donors are confirmed to have markers for Hep C. So when a test is introduced, repeat donors are newly tested and a look back should occur. However, this was another criticism of the Infected Blood Inquiry, that it took too long before this large-scale hepatitis C exercises started in 1995. So we had over 5 years of testing and 5 years of donations to look back on. So first you have to identify the relevant donations that these donors may have given, and then the hospitals have to be written to and asked if they can identify who was given that donation or whether the donation was used. The look back exercise started years after we introduced screening, and that delay may have caused problems in trying to identify the donations and the recipients, many of whom had died and so were not available for testing by the time the look back was undertaken. And in fact, there were only around 1,300 recipients tested in that look back, and half of whom were found to have hepatitis C. We still hold the information in that look back database, so we are able to search that database if anybody wants to know if they were part of that exercise and identified at that point. And we've been doing that for people coming through the system. So in terms of recognizing the risk, yes, slow to act, and we need to kind of not wait for perfect information or the perfect solutions. We should have addressed risks to patients more quickly, and that requires clear structure for decision making, to have the right expertise and to have that expertise listened to. And donors are drawn from the general population, so of course that speaks to the wider public health and horizon scanning in public health as well, to ensure that we're more alert and vigilant to risk. And then part of the reason our group was set up in 1995 was to get that more coherent approach to the data. So now we collect UK-wide data. Since 1995, we also collect data for the Republic of Ireland as well, so we can provide information and have done for policy decisions since then, and to provide assurance. So nowadays, there are many different steps on the blood donation journey. So we've focused on testing, but of course, donor selection remains crucial to avoid people at higher risk coming to give blood, because the lower the incidence of infection, the lower the residual risk of missing very recent infections with the screening tests. And then, of course, quality control, correct storage, pathogen inactivation where relevant, and of course, patient blood management. So that's minimizing unnecessary transfusions and acknowledging that transfusion carries a small risk of infection that remains even despite screening. So this is the estimated residual risk as of 2024. It's recalculated on an annual basis. We have to take 3 years worth of data to calculate these, although they still have quite wide confidence intervals. The risk is around 1 in 1 million donations screened. So that's the risk of not detecting and releasing that donation. It's not the transmission risk. And that equates to around 2 hepatitis B positive donations that we might miss every year. So it's highest for hepatitis B because hepatitis B has the highest and the longest window period of around 30 days. So even with the NAT testing, that risk is higher for Hep B. The risk is much lower for HIV and hepatitis C nowadays, and that's because the window periods with NAT testing are much smaller. And for Hep C in particular, we hardly see any incident infections in our repeat donors. We follow this very closely. It gives us a general direction of travel. And we saw in 2024 that the risks have slightly increased for HIV. Now that's based on 6 repeat donors seroconverting, so acquiring their HIV within the last 12 months before they came to give blood. So that's raised that residual risk very slightly. And that was 3 men and 3 women, 4 of whom reported heterosexual contact. And what we think is happening is that in the general population, HIV testing since the COVID pandemic has not recovered to the same levels as it has done previously in heterosexual men and women. So testing helps people know their status, it helps reduce onward transmission in the general population. And because HIV is generally decreasing, and most people living with HIV will know their status nowadays, that enables us to keep blood donation safer as well. So it's not just around blood donation, it's public health as well. These are the observed transfusion transmissions. So the residual risk is not the risk of transmission, partly because a donation may be released but not used, or the recipient may be immunized against hepatitis B, for example, so they may not be susceptible. So these are reported to the Serious Hazards of Transfusion program, which has been ongoing since 1996. It's a passive system, so it relies on the vigilance of people in hospitals to recognize that their recipient might have an infection, and to look for that and to report it to the blood services for investigation. So these are investigations that were instigated on the hospital's request. And you can see that the last hepatitis C proven transfusion transmission in the UK was in 1997. For HIV, that was in 2002. The prion transfusion transmissions occurred before leukodepletion safety step was put in place, and they were detected through the CJD surveillance scheme. So those were 4 transmissions via blood transfusion. So it's not without risk, and you can see that the most recent hepatitis B transfusion transmission was a probable transmission in 2022. And so these ones with the purple boxes, these were potentially due to what's called an occult infection. So the surface antigen screening doesn't pick up occult infection. And so once that risk was recognized, SABTO reviewed that and decided the best screening options to be able to pick up those occult infections, and introduced core antibody testing at least once for every donor from 2022. So, and we're picking up, we've picked up over 20 occult infections in donors since then that we wouldn't have otherwise picked up. These are the 2024 investigations. So hospital reporting to the blood services is one way the investigation will be kicked off, but of course, look back on a repeat donor who's newly identified as positive will trigger a look back on their previous donations. So for the screen negative donations, we hold the archive samples for 3 years in NHSBT, and we can go back and retest those using individual testing at the reference laboratory. And we can trace their history, and we can write to the hospitals and ask what happened to the donation, and work with the clinical care teams to work out how to trace and test the recipients. So 0 transfusion transmissions were identified in 2024, either from hospital reporting or from the lookbacks, but there were 2 near-miss Staphylococcus aureus. So the non-specific bacterial screening, looking for general bacterial infection in platelets, they're released as negative to date. So they're negative at the point that they go out to hospitals, because we need to get the platelets out quickly. So they may be picked up as positive later on, or the hospital might notice that a pack looks odd, where, you know, it's most common with Staphylococcus aureus because they might form biofilms and not be available for the testing. So it's important to remain vigilant and aware of that small risk of bacterial contamination. And just finally to mention the horizon scanning scheme that we set up in 2007 at the request of Dr. Pat Hewitt, who was the chair of SACTI at that point. This is a timeline of the emerging infection threats that have arisen just since 2003 up to the present day. This is on the UKHSA website. So there are new things emerging or spreading to new areas every single year that we have to risk assess and work out what to do with. So for some things, like dengue, for example, we can move quite quickly because we have a 28-day tropical deferral for dengue, chikungunya, yellow fever in place. And we can change the areas that we apply that deferral to. So for instance, people traveling to the south of France have to delay donating for 28 days on their return because of locally acquired dengue and also this year chikungunya in those areas, and we can add new areas on quite quickly. So as I said, that system's been in place since 2007, so we liaise closely with public health to create sort of a one-stop shop of all the current things going on that's been reported that month. We get daily reports into us from UKHSA, so anything that looks more urgent that isn't currently covered can be sent straight to the chair of SACTI. SACTI will then risk assess that list and decide who needs to act on that, and that can be done quite quickly, or they can ask for a new risk assessment to be done as well. That system is constantly refined based on feedback from SACTI and from UKHSA surveillance. It's been audited 3 times, and that helps us ensure that the processes are streamlined, remain timely and complete, and that the responsibilities for action are really clear. And this infographic just shows what things look like in 1996 compared to 2023, with the change in HIV status in the general population, the increased sensitivity in donation screening, the reduction in the window periods, and the reduction in the number of transfusion transmissions seen, although not zero, and seen in things that we weren't necessarily testing for at that time, and that malaria transfusion transmission arose because malaria is tested for if the donor understands that they need to report that infection. So we've been doing work to look at what would help donors understand when to report sort of past infection and past issues. And this is from our latest report, just showing how safety has been maintained in 2024, but that we are remaining vigilant, especially for the spread of arboviruses, which adds to the complexity and the cost, to look at donor eligibility to ensure that donors understand the donor selection guidelines, and also to make sure that recent infection remains low and what the causes of that, and if that is due to anything that we could improve on our end. And of course, it all relies on good collaboration and engagement with hospitals to help promptly identify any potential transfusion transmissions for investigation. And this is just a quote from the IBI: to avoid complacency, we can't assume threats are in the past. I've shown that they're constantly arising, and to learn the lessons. And I've put some links that I hope will be useful to how to report a suspected transfusion transmission shot, and to our team's reporting and our email if anybody thinks of any questions afterwards. We'd be more than happy to answer them.
Thank you very much, Claire. Gosh, there was a lot of shocking moments and facts in the talk, but I think that's the nature of communicating what you do. That if it's not a bit unnerving, we probably aren't listening correctly. Can I ask, what is the nature of success in you and your team's work when you are specifically looking for problems?
I suppose what we are looking to see is we're looking to see that the recent infections remain low, because as I said, the recent infection, the lower we keep recent infection, which means making sure that the donor selection guidelines are fit for purpose, and that the donor's understanding of that is fit for purpose as well, and to make sure that we've communicated that out to the relevant teams around the blood services to act on that information as well. So it looks, I guess it looks like that we're seeing low numbers, and that our residual risk estimates remain low, and that we aren't seeing transfusion transmitted infections. So we just want to ensure that those numbers remain low and avoidable, and to be able to, feed into policy reviews and feed that information to the right places at the right time, essentially.
Yeah, perhaps you mentioned this just before the talk, and it's that gravity of that next step that you're wanting to surveil the world and organize the structures that keep it moving at the same time. That's a heck of a brief. It was a really wonderful talk. So just think about when we're in clinical practice, whether we have an answer to a problem we haven't even considered with a patient yet. And that's going to give us our framework to hear from Sophie Pearson. Now, Sophie's a healthcare lawyer at Kennedy's Law LLP based in London. She qualified as a solicitor in 1996 and has specialised in clinical negligence ever since, initially working in claimant practice, soon shifted focus to defence work, representing clinicians and hospital trusts across London for over 25 years. Her experience spans both private practice and in-house roles, notably at King's College Hospital, and that's where we work together. I found working with Sophie really, invigorating and enlightening. We worked on some problems together. I am absolutely delighted she's here to talk to us today. Again, the title's on the slide, and I'm going to be quiet. Thank you so much, Sophie, for joining us.
Phil, thanks very much for that introduction. So what I'm going to do this afternoon is just talk about the general principles of consent. But of course, transfusion practice falls within those principles. So by giving you an outline view about consent, what it is, what it means for clinicians, people on the ground having to consent patients, I hope this is of some use to you. What I'm going to do is talk about the impact of Montgomery. Now, some of you may be aware that there was a landmark Supreme Court decision in 2015 which redefined the legal test in relation to consent. I'm going to discuss what that means on the ground, and I'm also going to consider the way that GMC guidance has changed in the light of the Montgomery decision. So what is consent? Well, essentially, it is the voluntary and continuing permission of the patient to receive particular treatment. And what it means is that there has to be, on the part of the patient, adequate knowledge of the purpose, nature, likely effects and risks of the treatment, including the likelihood of its success and any alternatives to it. So essentially, that encapsulates what consent is. Now, moving on to Montgomery, this was a very sad case involving a claimant, Nadine Montgomery, who in 1999, it goes back that far, had a baby who was severely damaged. She was diabetic. She was deemed to be a high-risk pregnancy, and essentially diabetic mothers tend to have larger babies. In essence, there was a 9 to 10% risk of shoulder dystocia during delivery. she was not informed of the risk. The treating obstetrician, Dr. McClelland, considered the possibility of it causing a serious problem was small, and decided her practice was not to mention the risk of shoulder dystocia, because she thought that actually if she mentioned the risk, mothers would always elect for caesarean section, and she did not think that caesarean sections were in the best maternal interest. So she declined to discuss the risk of shoulder dystocia with Mrs. Montgomery. Unfortunately, shoulder dystocia did occur in this case. It was managed in a way that was unable to prevent injury, and her baby suffered severe brain damage as a result. So at the time, the standard of consent is based on the Bolam principles. Now, for those of you who have any familiarity with clinical negligence law, the Bolam principle, or the Bolam test, is the test that is applied to the standard of care provided by clinicians to decide whether the care is adequate or not. And it essentially says that a clinician is not guilty of negligence if they have provided care which is in accordance with a responsible body of clinical practice. Now that, until the Supreme Court decision in Montgomery, was the test that was applied to issues of consent. So in cases involving issues of consent, the parties would adduce expert evidence to comment on whether the standard of care provided was in accordance with a responsible body of clinicians providing that treatment. Now, the judge or the Supreme Court in Montgomery considered that the Bolam test should no longer be applied to consent cases, and they concluded that she should have been informed of the risk of shoulder dystocia. She should have been given the option to have an elective caesarean section. They went further, as you have to do in a clinical negligence case, to look at what's called the factual matrix, the hypothetical factual matrix. They decided that if she had been told of the risk of shoulder dystocia, she would have chosen to give birth by caesarean section. And then consequently, it was agreed, and this wasn't a difficult jump, it was agreed that had an elective caesarean section been performed, the baby would have been born uninjured. So she succeeded eventually in the Supreme Court, which was in 2015. She had to wait a long time for that decision. So what is the duty then that Montgomery sets out? What is the Montgomery test? It is defined as follows. The doctor is under a duty to take reasonable care to ensure that the patient is aware of any material risks involved in any recommended treatment and of any reasonable alternative or variant treatments. So this essentially means that there is a shift from the Bolam test to the Montgomery test. There is a shift in focus from that of the reasonable doctor, what the reasonable doctor would expect to tell to a patient, to a reasonable patient. So what the patient feels that they are entitled to know about. So it involves a change in public attitudes. It involves a move away from medical paternalism. Lady Hale, in the Montgomery case, was fairly scathing of the decision by Dr. McClelland to withhold information about the risks of shoulder dystocia, on the basis that exhibits a degree of medical paternalism which is no longer applicable. The the courts and the law is going towards the attitude that patients are the holder of rights rather than passive recipients of care. So the duty involves this concept of material risk, and that was defined by the court in the case, and it defined it as follows. The test of materiality is whether, in the circumstances of the particular case, a reasonable person in the patient's position would be likely to attach significance to the risk, or the doctor is or should reasonably be aware that the particular patient would be likely to attach significance to it. Well, that's rather a mouthful, but essentially it involves the law taking a case-by-case approach to cases involving consent, involving, first of all, the nature of the risk, second of all, the effect on the patient's life if that risk materializes, and thirdly, the importance to the patient of the benefits of a particular course of treatment. So in looking at material risk, there are a number of further considerations which apply. And the law since Montgomery has grappled with those in various case law judgments. So the first point is whether a risk is material doesn't only depend on how frequently it occurs. In the past, there was a tendency to apply a rule of thumb. You know, if there is a 1% chance of something happening, a risk materializing, then you need to talk to your patient about it. If there's less than a 1% risk chance, then you don't really need to do so. The boundaries are far more blurred now. And it is not simply a question of saying more than this percentage risk, we must explain, less than this, we don't have to. It depends on a whole series of considerations. So the clinician's advisory role involves talking to the patient really to make sure that they understand the risks and benefits of their treatment so that they can make an informed decision. So it's really up to the clinician to satisfy themselves that the patient has understood what they are telling them. Simply getting a patient to sign a consent form, getting a signature on a consent form, may not be enough to evidence proper consent. And I've been involved in a number of cases where I've spoken to the treating clinician and they've said, but look, this consent form was signed by the patient, as though that is sufficient. And I'm afraid it is not. The courts go behind the consent form to examine the process of consenting a patient to satisfy themselves whether or not that signature really does mean that the patient gave informed consent. The doctor has to exercise reasonable care to ensure material risks are disclosed, and information has to be conveyed with reasonable skill. And I've mentioned this case of Connolly versus Croydon Health Services NHS Trust, because it involved a patient who criticised an information leaflet that had been given. Because very often, as you know, you will have a consent process which results in a patient signing a form or agreeing to treatment. But accompanying that consent form, there are very often information leaflets which are sent to patients. And in this particular case, she argued successfully that the contents of the information leaflet was insufficient and was misleading. And whilst the court accepted that, it actually concluded that the fact that she was misled in relation to the information leaflet didn't vitiate the consent, because taking the consent process as a whole, they were satisfied that she was properly consented for the procedure. But it is worth mentioning the point about making sure that information leaflets are correct and not misleading in any way. There are a number of exceptions to the Supreme Court decision. The first is what's called the therapeutic exception. And that is where they accepted that there may be circumstances where disclosure of full information about risks may be detrimental to their health. In other words, there may be a vulnerability that the patient has, where if they are told about all the risks, they will categorically refuse to have the surgery or the treatment. And actually, there are some few cases where it is better to withhold some information because really it is in the best interest of the patient to have the operation. Now, the court made it very clear that this is a limited exception and that it'll only be applicable in rare circumstances. So a real red flag here. Don't take away from this the idea that actually, if you think it's in a patient's best interests, you can willy-nilly sort of moderate the amount of information that you are given to them. It is only in very rare circumstances that is permissible. The second exception was, unsurprisingly, in relation to necessity. So where treatment's required urgently, but the patient lacks the ability to make a decision themselves. So in other words, if they don't have capacity and they need life-saving treatment, then you do not have to go through all the hoops in relation to consenting a patient. If the patient, you can treat the patient in their best interests, and a consent form 4 is completed. Patient choice is the third exception, and it's a point that is worth making, which is that there may be, and again, this will be a very minority of patients, there may be patients who indicate that they don't want to know the risk. They want the procedure, but they are of a nervous disposition, and they make it absolutely clear that they do not want to be informed of the risks. Now, again, I imagine that this will be very few patients indeed, but if you do come across a patient like this, documentation is key. You need to make absolutely sure that the reasons for them not wanting to be informed of the risks are made clear. It may be a good idea to have that decision witnessed by another clinician. Document, so that if that decision or if the treatment comes back and bites you, you have clinical notes which set out the thought processes of the patient, and what explanations were provided by the clinician, and a patient's signature. So those are the three exceptions. Now, in relation to GMC guidance, although Montgomery was redefined the legal test in 2015, GMC guidance had been moving towards that position previously. But just to give you some idea of the stance on risk information, 2008 guidance stated that you must give patients the information that they want or need about the potential benefits, risks and burdens, and the likelihood of success for each option. The 2020 guidance modifies that a little and says you should usually include the following information when discussing benefits and harms. Any risk of serious harm, however unlikely it is to occur. So whilst clinicians might be concerned about the change to any risk, however unlikely, changing the must to the should suggests that the overall meaning hasn't really altered. And the GMC said in their guidance that it it's actually less prescriptive on this point, and they have said that they've changed the wording from must to should usually, because they're trusting doctors to use their professional judgment to apply the guidance in proportion to the specific circumstances of the decision. So the GMC guidance hasn't changed significantly on the advised level of risk communication, but it's notably beyond Montgomery in the sense that Montgomery said that you need to explain a 9 to 10% risk, which was the risk of shoulder dystocia. And the GMC guidance is saying, no, actually, you need to be more rigorous than that. You need to discuss risks, probably, which go way lower than a 9 to 10% risk. So what does this all mean in practice? You have to give patients the information they want or need to make a decision. So this obviously includes diagnosis, what you think the diagnosis is, what you think the prognosis is. If there is any uncertainty about the prognosis, there may be options for further investigation before you launch into treatment. And the possibility of further options for investigating a patient's diagnosis or prognosis, they need to be discussed with the patient as well before you proceed to recommending or advising a treatment. You must discuss the options for treating or managing a condition. And this involves, and it's really important, involves the option to take no action. There is always the option of taking no action. No patient is obliged to accept the recommendations of the treating clinician. So this is something that you need to bear in mind when you are speaking to your patients, the option of actually doing nothing. Once you've talked about the range of options, you then need to drill down into each option, and you need to explain what is going to be involved, what the desired outcome is. You need to consider and discuss the potential benefits to them, the risks of harm, the uncertainties about the likelihood of success for each option, including the option to take no action. So there is a fair amount of information that you need to give to your patient, and arguably, and I would say almost definitely, more information than was previously the case, because of the emphasis on satisfying the particular patient that you have in front of you, that of the options available to them. And indeed, the GMC guidance warns against making assumptions about patients. And I think that this is quite easy to do because of the experience that you have as clinicians. You might get a sense of what the general population in terms of the patients that you have seen in the past might want or need, according to what your practice has been. So you shouldn't make any assumptions about what a patient might want or need. You shouldn't make any assumptions about the factors that a patient might consider significant before you've spoken to them, or the importance that a patient might attach to different outcomes. Essentially, you have to put the patient at the centre of the consent process in a way, arguably, that you did not need to do under the old Bolam principles. So what does it mean? It essentially means listening to patients, encouraging them to ask questions. So you have to find out about their health. You need to find out what is important to them, what activities they do, both personally, professionally, what is important to their quality of life, so that you can support them to assess the likely impact of the potential outcomes for each option. And you need to explore with them the risks that they would and wouldn't be prepared to take to achieve a desired outcome, and how the likelihood of a particular outcome might influence their choice. In terms of risks and benefits, you need to give them clear, accurate and up-to-date information based on the best available information and evidence about the benefits and risks of harm of each option, again, including this option to take no action at all. In reality, it's not reasonable to share every possible risk of harm, potential complication or side effect. And I can imagine that for those clinicians who have been involved in clinical negligence cases and have been stung by a consent case, the tendency is to want to explain every single risk, even if it is a risk of, 1 in 10,000, 1 in 15,000. But the law says, no, that is not necessary, but you have to tailor the discussion to each patient. So you have to know who is sitting in front of you, what their attitude to risk is. You have to be guided by what matters to them, and you have to share information in a way that they can understand. So what do risks and benefits actually mean? You need to explain to them the risks, the recognized risks of harm you believe that anybody in the patient's position would want to know. Then you need to talk about the effect of the patient's individual clinical circumstances on the probability of a benefit or harm occurring. So, for example, if the age of the patient is important, if they're older or younger, or it makes it more likely for there to be a risk, or indeed less likely for there to be a risk. This is something you need to discuss with them. If there are comorbidities, you need to consider whether those comorbidities increases the risk of a particular risk materializing, and if so, you need to discuss that with the patient. You need to then personalize your discussions depending on what this if you are dealing with a musician or somebody plays the piano, plays the violin, and you're talking about, orthopedic hand surgery, for example, then knowing the importance to them, then you need to consider whether to discuss risks which you may not discuss with a member of the public whose manual dexterity is not important. So you really need to drill down into the patient's history, background, likes, dislikes, interests, to decide whether you need to select further risks which need to be discussed with them. And you need to discuss any risk of serious harm, however unlikely it is to occur. So that's why on a fair number of consent forms, the risk of death is mentioned, even if it is very unlikely to occur. You need to discuss expected harms, common side effects, and what to do if they occur. And consider using visual or other explanatory aids to support the patient to understand their personalised risk. Coming back to consent forms and information leaflets. Information leaflets can form part of the consent process, and so consider whether information leaflets or visual illustrations might assist a patient to understand. So you've really got to get under the skin of the patient. And what this means, I can hear many of you thinking, well, do we have time to do that? We have 10 patients to consent this morning for this particular surgery. Where do we find the time? And you have my understanding, you have my sympathy, and that is a question that was raised on a number of occasions when I worked as an in-house lawyer. The reality is that the law will expect you to provide a decent, ethical, proper consenting process. Coming before the court to say, I actually didn't have time because I was rushed and I had another 9 patients to consent, is not a defence, will not be a defence to allegations of poor consenting. The expectation is that you must provide, and you must provide sufficient consent process, that you must find the time to explore all the relevant consenting issues with your patients. So moving on to consent and treatment in an emergency, and I know that this will be relevant to transfusion practice. Clearly, consent in emergency situations has different considerations because decisions need to be made quickly, and you have less time to apply the guidance in detail, but the law says that the principles remain the same. Clearly, the law will take into account the fact that you may have less time to consent a patient. If that is the case, then there needs to be a proportionate approach. You need to decide how to best consent a patient when they are requiring emergency care. But there is a presumption that a conscious patient has the capacity to make the decision. Obviously, every time you are consenting a patient and in an emergency situation, you need to decide whether you think that patient has capacity and act accordingly. And you do need to, on the basis then that there is a presumption that if your patient is conscious, they have capacity, you need to seek their consent before providing treatment or care. If a patient's unconscious, and this will be information that you will all know, or they lack capacity, then you can provide that treatment if it's immediately necessary to save life or prevent serious deterioration. If the patient regains capacity and is sufficiently recovered, that is the moment then to have a discussion with them about the treatment that they've received and the treatment that you recommend going forward to get consent for treatment going forward. Delegation. You can delegate consent discussions, but you must make sure that the person you delegate to is suitably trained and competent, has sufficient knowledge of the intervention and its associated benefits, as well as alternative options for treatment and care, and has the skills to have the dialogue with a patient that's in line with GMC guidance, and feels competent to carry out the delegated task and feels comfortable about referring back to you or another appropriate colleague for further information if they feel that the thing is getting out of their depth and they don't feel able to provide the necessary consent. But beware, if you delegate the consenting process, you are still responsible to ensure that all the relevant information and risks and benefits have been provided to the patient. And you may make the decision that in cases of serious medical treatment or complex cases, for example, it simply isn't appropriate to delegate consent, and that you need to carry out the consenting process yourself. And a key, as far as lawyers are concerned, a key issue is recording the consent process. You need to keep an accurate record of the exchange of information, which leads to a decision that a patient is going to have particular treatment. Now, in very many cases, consent is an ongoing process. It doesn't begin and end with presenting a consent form to a patient and asking them to sign it. In complex surgical cases, for example, the consent process starts way back. It starts back in the first clinic and is an ongoing process. And in those cases, the court is not simply going to look at the consent form. They're going to go back through the clinical records. They're going to look at the clinical notes. They're going to look at what you explained to a patient about the particular procedure, all the way through until the consent form has been signed. Even if a consent form is signed, then that's, for example, 2 weeks before a procedure, it's always then a good idea when the patient comes back into hospital to ask them again whether they still wish to undergo the particular procedure. I mean, there are obviously other cases where the consent process is carried out very quickly because a patient comes into hospital, needs immediate treatment, the consent form is given to them, they sign it, and off you go. So there's a whole range of consenting timelines, if you like. But in terms of the consenting issues involving patients, which go back over several months even, remember to keep asking the patient whether they still wish to continue with this particular procedure. And less is more, as I've said on the slide. This doesn't apply to consent. You can't, in my experience, you can't be too careful about documenting carefully all of the risks and the benefits that you have explained to the patient. It's very easy when a patient undergoes an operation or a procedure which goes wrong for them to suggest that actually the consenting process wasn't performed correctly, even though a consent form has been signed. And the devil is in the detail, and the more information that the lawyers and your legal teams have available to them demonstrating the consent process, the better we can represent your interests in court. So that's it. If there are any questions, I'm very happy to take them.
Well, we're going to hear now from Jason Evans, who's very kindly going to speak to us. Is a user consultant on the Infected Blood Compensation Authority. Jason is the son of one of the victims of the infected blood scandal. His father, Jonathan, was infected with hepatitis C and HIV through blood products. And Jonathan sadly died when Jason was 4 years old in 1993. And Jason was previously the director of Factor 8 and Infected Blood Campaign Group, and last year received a Pride of Britain Award for his role in bringing about the inquiry and the compensation scheme while supporting those who are infected and affected. Jason's now a user consultant at the Infected Blood Compensation Authority, helping to deliver the billions of pounds in compensation which has been set aside by the government for victims and their families. So we're delighted you've given us the time to speak, Jason. As you can see, the title is on the slide, and again, the floor is yours.
Thanks very much, Phil, and it's truly a pleasure to be here. And although I do work for the Infected Blood Compensation Authority now, I'm very much here today to talk as well about, as you heard Phil mention there, my personal experience and views on this, which I thought it was best to start with. And so my father, Jonathan, he was born with the bleeding disorder haemophilia. And you see two pictures there, one when I was a baby with less beard going on, and then also another picture there of my dad, which was close towards the end of his life. By then he had developed AIDS. I also had an uncle who also had haemophilia, being of course a hereditary condition. So both my father and uncle were infected with HIV, hepatitis B and hepatitis C. Such was the risk of Factor 8 and Factor 9 concentrate products at that time. And my father died in 1993 as a result of his infections, and my uncle a few years later as the result of his. And what I wanted to use the time for today really was to then move on to look at not just my personal circumstances, but what the whole infected blood community have been through in that period since the time these infections were taking place until today, where we have, of course, the Infected Blood Inquiry report published in May last year, and now the compensation scheme in place. So before we do that, I thought, although you will be no doubt familiar with some of the headline findings of the IBI, maybe just to highlight a few of those. So the licensing failures to revoke licenses for these factor 8, factor 9 products. The UK was not self-sufficient in the manufacture of its own blood products at that time. Increasing the size of the plasma pools when the risks were well known. Failures on research and development when it came to heat treatment, viral inactivation processes. Failures to use safer treatments at the time, such as cryoprecipitate, plasma, etc. Falsely reassuring the public and patients. The inquiry found that ministers of the day understated the risks, as well as some of those in the medical profession and the manufacturers, failing to tell people of the known risks. Unethical research, obviously we've had that great talk today on issues of consent, and I think one of the really important things about the IBI report is it makes 5 references to even the Nuremberg Code, and it also highlights the Helsinki Declaration as being possibly contravened in these matters. People not being told that they were infected with HIV or hepatitis in a timely fashion. It's common that it was recorded in medical records that a person was infected for at least months, often years, sometimes even decades before they were told of their infection. And then, of course, the cover-up, one of the headline findings, the failure of the state and others to talk about the truth of what had happened. And of course, there's the infamous statement of Sir Brian Langstaff, the chair of the inquiry, where he said this was not an accident. So I talk about that journey that people have been through over the decades. I thought we should start really in 1985, because that's the year when most people infected with HIV through blood products begin to either find out or be told that they are infected with HIV, and naturally you begin to see not just the devastating consequences of that, but the outrage of that from the community. And so in 88-89, the first legal actions begin against the government. They eventually become a group legal action. And as a result of that legal action, the government established a charity called the Macfarlane Trust, named after R.G. Macfarlane, who was a haemophilia specialist. And that charity was essentially set up to pay out relatively small sums to end that litigation. And although the amounts varied, to give you an example, if you were a single man, you would have been paid £23,000 for being infected with HIV, which I think by anyone's standards is not really reflective of that level of harm, particularly at a time where HIV infection was a death sentence. There of course was no effective treatment at that time. Coming forward then into the 90s, really, a number of things happened. Firstly, the majority of the HIV infected haemophiliacs, of which there were around 1,250, they die from AIDS. There are today only somewhere between 200 to 300 HIV infected people still alive, and so the majority of those kind of claims for compensation will be on behalf of the estates of people that have died. Also, people, both those who were infected with HIV and those who were not, begin to either be told about or to find out about, as we saw in the earlier talk. 91, we have the Hep C test introduced in the UK, and so people begin to be told and find out about their Hep C infection. Pretty much universally, everyone who was infected with HIV was also infected with hepatitis C, and that's because although the imported pharmaceutical blood products were much more risky for HIV, every bottle of factor 8 or factor 9 concentrate produced during the 70s and 80s that was not subject to viral inactivation was infected with hepatitis C because of the prevalence of the virus in the population. And so if you were given those products, hepatitis C was pretty much inescapable. And as a result, we then saw the campaigns for hepatitis C support / compensation begin. Coming into the 2000s, aside from the points I'll go through here, people are getting ill, not just from AIDS, because many of those who would die from AIDS have already died by this point, but also hepatitis C, those chronic effects, the damage to the liver. More and more people are developing, serious cirrhosis, liver cancer, etc. Various government-produced reports at this time find nothing was done wrong, and this was all an unforeseeable event. Eventually, in 2004, something called the Skipton Fund was established. This was similar to the Macfarlane Trust that had been set up for people infected with HIV, except this was to provide very limited, akin to benefits, monthly payments to those living with hepatitis C infection. Then in 2009, we had something called the Archer Report. That was an independent review that was set up by Lord Archer of Sandwell, who's now sadly passed away. Well-intentioned though it was privately funded. It was done on a shoestring budget, really. And as a result, it had no powers to compel civil servants or ministers, for example, to give evidence. It didn't have the insurance to cover itself, to find fault, really. And so although it did recommend compensation, it didn't carry much weight. And frankly, still at this time, it was simply not accepted by a majority of Parliament that what had happened was a scandal. It was still seen as this accident. And then latterly, we had something called the Penrose inquiry, which was a Scottish inquiry. Like the Archer inquiry, it had limited powers for slightly different reasons. This time it was because it was a Scottish inquiry, its powers ended at the Scottish borders. It couldn't compel witnesses outside of those borders. It made a single recommendation, which was that anyone that had received blood before 91 should be tested for hepatitis C. And that was that. It did not find any fault or that anything really had been done wrong. And really that moment, this was in March 2015 when the Penrose inquiry reported, for me personally, but for the whole community, it was a really, really important moment. Lord Penrose, who had undertaken that inquiry, did not turn up to the final report. His secretary was sent instead, who you can see pictured in the image there. And for me personally, it was a trigger moment for me to get involved in campaigning. And I'll just take an aside at this point to say, if there are any questions, do feel free to pop them in the Q&A while we're going along, and I'll get to them at the end. Nothing is off the table. Anything people may want to ask, please feel free. So 2015, 2016, this trigger moment, I decided to set up a new campaign group called Factor 8. No prizes for guessing why the name Factor 8 was chosen. But really, Factor 8 had two goals. It would not focus on monthly support payments or anything other than what could perhaps bring some real form of closure to the community. And those two things were a full UK-wide statutory public inquiry and, of course, full and proper compensation. So at that point, I began to connect with other people that had been impacted by the scandal for the very first time. I helped to organise demonstrations and protests, and you can see in the image on screen, that was a protest in 2016, April of 2016, outside of Parliament. And the person you can see in the foreground there, who is painted red, is someone who became a very good friend of mine called Tony Ferrugia. And this whole thing about painting his face red was influenced by some fellow campaigners in the USA of what they had done previously to highlight both AIDS and the blood scandal itself. But mainly it was a way to try and help get press attention for what at that point was already a 30-year-old story to many people. We held film screenings of documentaries. I personally began learning everything I could about the scandal, everything that had gone on before, researching at the National Archives. The Wellcome Trust Archive in London was a great resource too, and connecting with counterparts overseas. So US lawyers, campaigners in Canada, people in the Netherlands, really, because this was a global scandal and global event that took place, there were lots of pots to be able to go to and speak to. And then in 2016, myself and others began working with BBC Panorama on a documentary about the scandal. And then 2017, this is really a pivotal year of change in this fight, which by at this point has been going on for decades. Not any single individual necessarily, because what would happen is someone would start campaigning, they would get sick, they would die, someone else or some other group would then carry on the baton. But at this point in 2017, a number of important things happened. First of all, I met with others, Andy Burnham, who many of you will know. He's now the Mayor of Greater Manchester, was formerly an MP. He had held something called a Justice Summit in Parliament, where he had asked myself and others to attend, along with people affected by other injustices, e.g. Hillsborough, Birmingham pub bombings, etc. And I spoke there about the infected blood scandal to a number of MPs and peers, but also to lawyers, including Des Collins and Danny Holliday from a firm of solicitors called Collins Solicitors, who would prove important to the next events that followed. Next, in the April of that year, Andy Burnham used his final speech in the Commons to talk about the infected blood scandal. It was a good 2 or 3 hours from memory, and it really helped to kind of embed this scandal kind of in the consciousness of the Commons, particularly as Andy was himself a former Secretary of State for Health, so it coming from him carried a lot of weight. A month later, that episode of BBC Panorama we'd been working on aired. It went out and it announced that Des and Danny, who I'd met in the February, Collins Solicitors, were going to take a legal action in relation to my personal case against the government. And then this week here, the 4th to the 9th of July, was when everything changed. First of all, that personal legal action actually became a group litigation. And so it was no longer just about me taking that legal action. It was about gathering everyone, as many as we could from around the community, to join that legal action. Secondly, I'd been working for some time with the Daily Mail on a front page news story. I didn't know until the day it was published it would be a front page news story, and in fact I was quite shocked when I woke up to see the Sky News press preview and the Sky News in the morning, which you can see on screen there, to see it had also made it onto the TV. I thought we'd probably get a quarter page buried halfway down the paper, and whatever you may think of the Mail, certainly at the time it was the most read newspaper in the UK, and as a result it brought a lot of public attention back to the scandal. In that same week, the Times then reported on that same evidence, and by the way, that evidence, that front page story, it was about some of the very issues that have been discussed today. It was about people being used as human guinea pigs, which I know is a bit of a cliche. It's an allegation that's often made, but of course we know from the IBI report, in this case, it was true. And that Times article not only reported on the Daily Mail evidence, it also reported on the fact that leaders of all of the opposition parties in government at that time had signed a cross-party letter saying that there should be a public inquiry into the infected blood scandal. So all of that happened in the space of 1 week, and I wish I could tell you it was all cleverly orchestrated to happen in that 1 week, but beyond one or two things, it was a case of stars aligning, really. And then suddenly, on the 11th of July 2017, the infected blood inquiry was announced, and Minister said to the Commons, in the light of those concerns that had been raised and of reports of new evidence and of allegations of potential criminality, which was the stick Andy Burnham was brandishing, we think that it's important to understand the extent of what is claimed. And I have to tell you, everyone in the community, including myself, was completely shocked that we had done it. There would be a UK-wide statutory inquiry. I was sat at my desk at work, and it was actually a colleague of mine, the accountant of where I was working at the time, said, "Oh, you know, congratulations, I've seen the news." And I said, what are you talking about? What do you mean? And then he showed me his phone with the BBC headline, and I said, I think I need to step out for the rest of the day, actually, and make a few phone calls. So it was really an incredible day. And then well, not much happened for a while from the community perspective. We had a lot of arguments around how the inquiry should be led. At first, it was proposed the Department of Health should lead the inquiry, and that did not go down well with the community, given that was the department seemed to be responsible for the scandal. Eventually, it was moved to the Cabinet Office, and then, as we see with some inquiries now, there are those discussions that need to be had around who the chair of the inquiry should be. We know ultimately it was Sir Brian Langstaff, but it wasn't until September of 2018 that those inquiry hearings actually began. It's not my intention at all to talk about the pandemic at length, other than to say, of course, during that period of hearings, we had COVID, and it was a very worrying time for the community on a number of levels. We didn't know if people infected with hepatitis C, HIV, would be at greater risk if they caught COVID, and what that, you know, would mean for the community. We didn't know if our inquiry would just be totally overshadowed by what could have come and was going on. And so it was really a very difficult time. But nonetheless, the hearings adapted and they went on. We had two interim reports, the first of which recommended interim repayments for living infected people and bereaved partners. And then the second of which was recommendations on a full compensation scheme, which was published in April of 2023. But not much happened with that report until we got the final report, which was in May of 2024, which of course found all of the damning things that we've discussed. And it was within those same couple of weeks, the legislation that would establish the Infected Blood Compensation Authority then was rushed through Parliament, because that was also the time that the previous government exited. We actually had the inquiry report published, and then I think it was 2 days later, the general election was called. So there was a big rush to try and get the legislation through Parliament, and very thankfully that happened. And so I thought I'd just take a minute to reflect that I've been speaking quite quickly there because it's such a grand kind of period of time to condense down, and really it's only a small snapshot of the fight that went on. But that was 4 decades, you know, plus that people had been fighting. And that image you can see there is one of the display vans that circled around Westminster on the day of the report. There were a number of those on the day. And so as of today, I'm now a user consultant at the Infected Blood Compensation Authority. I'm very happy to say I'm no longer campaigning and fighting. That was a good decade of my life spent doing that. And I think the whole community really, I'm just thankful that it amounted to something. And I think now some people can find some form of closure. As of today, the latest published stats are that more than 3,600 people have been asked to start their compensation claim. Over 2,000 people have had their compensation paid. It's a total of well over £1.5 billion. So a lot that's being paid out already. But of course, there's still so much more to do. And IBCA now is gearing up to open up the claim service to people that haven't previously been on a support scheme, to the estates of people who have died and people who are affected, which includes children, parents, siblings, carers and partners as well. And so a couple of reflections. First of all, the patient family voice. I know it's a bit of a cliche, but I really don't think it can be underestimated. I think just by having me here today is an excellent example to see that's happening more and more. I went to a board meeting of the Oxford NHS Trust last year where there were patients present at the meeting sharing their experiences of care, both positive and negative, and I thought that was brilliant to see, and it's so important, I think, to the story of the infected blood scandal. Secondly, from everything I've seen, closure becomes impossible without truth and recognition. The old saying is justice delayed is justice denied, but I think the wider point for me that I've seen is that psychological closure just does not happen if people don't have the full facts about, you know, a negative experience that they've had or harm they have suffered through medical treatment. And thirdly, to end on a slightly more positive note, that change is possible, no matter how hard it can seem. You know, when we began on that campaign, this was very much seen as a 30, 40-year-old story. You know, hasn't this been dealt with? People should have moved on by now. People said to me, you know, if this was ever going to get anywhere, someone would have won something in court by now. You're wasting your time. You're leading people up a mountain for no reason. But you know what? With the goodwill of those infected, those affected, some great lawyers, great journalists, great politicians, that absolutely do exist, we were able to get somewhere. And so I just wanted to end by saying, if people want to hear more, because I've condensed a lot there, and I'll post some links in the chat in a moment. I always point people towards this ITV documentary, which I had a couple of years ago, In Cold Blood, a feature-length documentary that won an Emmy even, which I thought was fantastic. Then do feel to watch that. It's on YouTube. I'll share the link. Happy to go to Q&A if there's time. But actually, I did just have a short plea, if that's okay, Phil, before we do that. And the plea really is this. What's really important for IBCA is to identify everyone who is potentially eligible for compensation. And so to all of you listening, if there's any way in which you can help, you know, IBCA to find those people who might be eligible for this. And again, I'll post this link. Please do direct them. They can register their intent to claim compensation on IBCA's website. And if anyone is willing to use your NHS channels, socials, newsletters, whatever you may have available to share IBCA's website and share, you know, about the compensation scheme, please do feel free to reach out to me, and I'll drop my email in the chat as well. But Phil, over to you. I know we've been pressed for time, so happy to go however best.
No, thank you very much. In fact, I was going to reference Danny Gaskin, one of the team's questions. It was what would you like to see next? But it might be that you've just answered your own question. It is follow the clarion call you did at the end there and just do that. We've got 253 people on the call. Nella and I are going to get your instruction to as many people who are on the people on the call and who aren't on the call as well to do just that. And would that be a fair deal for that extra thing?
That would be amazing. Thank you.
Wonderful,
Thank you very much.
wonderful. There are a few questions in the Q&A. I'll just make the point there were times in that, even when you know what the ending's going to be, when I really didn't think I could, it was very difficult to hear it, even when you're on the inside. And God, you know the ending's not going to be as difficult as you think it's going to become. Thank God it ends slightly better than some of the years backwards. But you were living through it, so thank you so much for telling us about the experience. And of course, this is going to be posted. It's going to be on our channel, so other people get to hear it. So thanks again. If you've got a second to look at the Q&A, please do. As you say, Jason, I'm going to I'll move on to the next speaker. Thank you again. Now, Dr. Maria Guerra-Velos is a hepatologist from King's College Hospital with a specialist in viral hepatitis and liver cancer. His research is focused on early cancer detection and improvement in diagnostic pathways and treatment across treatment access for patients with viral hepatitis and liver cancer. And her topic, as you can see on the screen, speaks for itself. And again, I'm going to turn my chat off and it's over to you. I think you might be just coming into the room there. The floor's yours.
Oh, thank you. So hopefully everybody can hear me well. Thank you for the invitation. It's a truly honor for me to be here and share a few talks about viral hepatitis. I'm going to talk about the diagnosis, the treatment overview, but especially talking about the progress toward elimination. I don't have anything to declare for this talk. This is the agenda. I want to talk about epidemiology, why it's important to talk about hepatitis B and hepatitis C nowadays. I want to explain about the WHO elimination strategy for 2030. I want to talk about chronic hepatitis B, but focus on the news in the diagnosis and treatment simplification, and also with chronic hepatitis C, what happened in the last 10 years and how now we are able to say that we have been able to cure this chronic disease, and some take-home message. Why I wanted to talk and start with epidemiology, and this is very important because we know that there is still being an important proportion of patients or people who have chronic hepatitis. We are estimated that the 3.3% of the total population is infected by hepatitis B, and unfortunately only 13.4% of these are aware of this infection or that they have the infection. A much less proportion is only 2.6% of those ones who knows that they are or are under treatment. In terms of hepatitis C, we know that there's still been 50 million of people infected with this disease. And again, only 36.4% of them are aware about this diagnosis, and less than 20% have been already treated. Why it's important to talk about the WHO Global Elimination Program and the target that was set in 2015 is because the idea is to try to reduce the new cases of chronic hepatitis B and chronic hepatitis C. So we want to reduce the incidence to the 90%. And with this, we want to reduce 65% in hepatitis-related mortality. How we can assure that this is covered and what is expected from the services. The first thing is like at the childhood vaccination that we require at least a target of 90% with the third dose. Blood safety. We have heard about the blood donation screen, and that is happening, and the WHO wants that to be the 100%. Give like for the 100 oceans people like enough supply for them in terms of the sterile needles and syringe per person. And with those that have been diagnosed, that is 90% that we want to achieve, at least 80 of them to be treated and be cured for hepatitis B and hepatitis C when this is eligible. We can see in this graph, it was recently published by the Global Health Sector strategy in terms of hepatitis B and hepatitis C. And what I want to highlight is, if we don't do anything, if we don't improve the diagnosis, if we don't improve the treatment or the access to the treatment, it's unlikely that we can see, as here, a decrease in the number of new cases, and it's unlikely that we can see a decrease in the mortality related with hepatitis B, and also in the mortality related with hepatitis C. So this is telling us that yes, we have achieved an important goals with elimination of hepatitis C specifically, but there's still being a lot of things that we need to do. What is the important indicator factors that we need to take in consideration? And I think this is important because this is quite ambitious, and this is what we wanted to achieve by 2030. And as I said, is try to decrease the number of new diagnoses and treat more people and cure more people with hepatitis. In the terms of the indicators, and this is important for me because what we wanted to decrease is this hepatitis B surface antigen prevalence in children for 0 to 4 years from 0.94, that is the baseline or was the baseline in 2020, to decrease to 0.1%. So if the vaccination works, we need to see that decrease in the prevalence of infection in the child population. When we talk about the number of hepatitis B infection per year, we want also to reduce from this baseline that there was 20 cases per 100,000 to 2 cases per 100,000. In terms of hepatitis B or hepatitis C, the people who are dying for hepatitis B, we wanted to reduce from 10 cases to 4 cases, and in hepatitis C, for 5 cases to 2 cases. And what we are doing, or what we have been doing over the last 15 years, over the last 10 years. So we have been already reaching and trying to do some prevention. We have been trying to prioritize some population and trying to do some screening. But we know, and as I highlight in the first slide, is still being not enough. The majority, or 80 or 90% of people who are infected and are aware of that infection. And yes, we have improving the diagnosis. The access to treatment has improved. However, we know that there's still being a high proportion of population that is not underdiagnosed or under treatment. And after treatment is not old, so we need to make sure that those who are cured for hepatitis C or are suppressed for hepatitis B, we need to make sure that they need to continue being engaged with the care when there is needed, and also make sure that they are achieving a good health-related quality of life. That should be the priority when we talk about treatment. Sorry. Now moving to the chronic hepatitis B, and I said that why we need to talk about hepatitis B. There hasn't been major changes over the last probably 2 decades. And it's important because, again, 90% of the people are unaware of the diagnosis. And if we talk about the UK, specifically in our prevalence, the number of cases, we know that is quite low in comparison with another region. This is the UK. We can see that there is no, as in another areas, that there is high prevalence, but we know that it's approximately 0.3%, but up to the 80% of the cases are found in London. So we know that we have different ethnicities, a big city, pluricultural city, in which we need to do testing and improve that. And this will increase, and this will continue to evolve with the globalization, migration, and the movement of the refugees, in which we need to make sure that we are testing. I like this slide because this is quite old. This was presented in the HBV forum in 2018. And this is related that hepatitis B is one of the greatest global public health failure of the late 2000th century. And why we say that is because of, as I said before, there's not many things that are going to be new in the hepatitis B. The vaccines to prevent hepatitis B has been available since mid-1980s. So it's nothing new. It's a long time in which we have vaccination to prevent the transmission. We have antiviral treatment that has been available more the last 20 years. So nothing new, no major changes, good treatments to decrease the suppression of the virus, no curative treatment. But yet, every single day, we know that there are 3,000 people that die with their infection for hepatitis B. So there's still been a lot of things to do when we know that this is a disease that is not curable yet, but is a potential to be treated and controllable. Why we wanted to diagnose and treat the population with hepatitis B? Because we wanted to reduce morbidity. We want to keep the virus suppressed. We wanted to achieve the ultimate goal, that is the functional cure, that is basically the loss of this hepatitis B surface antigen. And also because what we wanted is to improve the liver fibrosis of the liver scarring. We want to improve any extrahepatic manifestation. We wanted to improve quality of life. We want to prevent the transmission, and we want to prevent liver cancer development. And what is the new? And this is for me important because, as I said, treatment vaccination has been with us for more like 2 decades. And the new that we have over the last year, and is also following the latest guidelines with the WHO, is talking about treatment simplification. So as a pathologist, we used to complicate ourselves in terms of hepatitis B with the diagnosis, with the different phases. We wanted to really understand who needs to be treated or no, try to have some cutoffs in terms of the number of virus before treatment, when we know now that if we treat to the majority of the patients, we're going to decrease transmission and we're going to decrease the risk of cancer development. So this is interesting because what we are basing in the model now is simplification. So if someone has a chronic hepatitis B because they have hepatitis B surface antigen positive and they have advanced scarring or cirrhosis, they need to be treated. And if they don't have advanced scarring or advanced fibrosis, but they have an hepatitis B DNA more than 2,000, they need to be treated. So basically, simplifications and try to treat the majority of those people who are infected, because if we treat, we decrease risk of the transmission, we decrease risk of complication in the liver, and we decrease risk of cancer development. This is another slide just to present something that we don't have. When we talk about screening, we know that there is no any policy in regards of universal screening. So there should be a recommendation that we need to test every adult for hepatitis B, hepatitis C, and HIV, but doesn't happen. So what we are testing is basic of risk factors. And again, we know that there is areas that are endemic, and with the migration, there will be higher prevalence in determined areas. But again, if we screen into those who have a risk of having this disease and this is positive, we are moving forward now to treat and treat more. We are not defer treatment because again, we know that the treatment could change the natural history of that disease. I want to move now to chronic hepatitis C. In the terms of chronic hepatitis C, there is a lot of changes, and I, as one of the liver doctors, I felt quite pleased with that because there has been a massive changes over the last 10 years in terms of treatment and treatment access. When we talk about hepatitis C, again, this is what the WHO would like to have at the target for elimination in 2030. This is in the number of cases per year, and I can tell that the progress in England is quite good. We know that we have decreased the prevalence of this disease by at least 51% in 2022, and also that prevalence has decreased by 68% in 2022 in those who are injecting drugs. So we are heading in that direction in which we are decreasing the new cases of hepatitis C. This is the estimated prevalence of the infection. This is what we have in the UK. This is the latest update that is from 2012 to 2023. We can see nicely how the number of cases or the known cases of hepatitis C has dramatically decreased. And by the end of 2023, we know that there is only 55,000 people who are infected by this infection. Here I wanted to highlight that this, we heard like from the previous speakers, we know about the blood donation, so there is at least 15% of population that they don't have a history injecting drug use and they have hepatitis C. And unfortunately, again, there are not all diagnosed and they know about the disease. The prevalence, as I said, has dropped, is only 0.12%, and we have a massive decline in almost 60% in comparison with 2015. So for me, that means that we are doing something, and we are doing something great, and we will see what has transformed all of this in terms of the hepatitis C in diagnosis and treatment. Again, this is just to show about the mortality related with hepatitis C. We have already a decrease of more than 31% reduction in mortality. This is related with the hospital admissions and cancer development from 2005 to 2020. And we can see how this mortality has reduced across all the UK. This is England, Scotland, and Wales. So this is happening, and is happening in all our country. And what is the main response of the big changes that we have experienced as a clinician over the last 10 years? And I want to put like a treatment evolution, because this is what has changed the natural history of hepatitis C. We heard already that we have patients that have been infected more than 20, 30 years, that they have already an advanced scarring, cirrhosis, or they have developed already complications for the cirrhosis. And what happened, because this is kind of the history about hepatitis C, we heard that before 1989, we called the non-A, non-B. That was in 1989 when we have the name. For hepatitis C, and that was discovered. We had a treatment that was the interferon. The interferon, that was a treatment that was no very success, that less than 50% of our patients achieved cure. But since 2014, we experienced an amazing revolution in this treatment, because we started having the first direct antiviral agents. So this treatment came in 2014, and over in the last 11 years, we have been able to cure the majority of the patients. We have issues initially with the type of the genotype, because we know there is a few genotypes that were traditionally difficult to cure, but with the access of these therapies and another pan-genotype therapy, so that means treatment that can be used for any genotype, we have achieved an amazing cure rates. So this is what has changed the landscape of hepatitis C. But to change the landscape of hepatitis C is not just the access to the therapy. It's another important factor that I wanted to mention, because this is what is leading to the UK to be one of the countries that is heading in the direction to eliminate hepatitis C. As I said, this is related with the access to the new therapies that will happen in 2015, but also with this invest to save and the allocation of the some of the resources to try to implement some simple testing, as the reflex test that was adopted in 2017, in which every positive hepatitis B antibody will be tested directly for RNA, and in which we will know if the patient have or not the infection. Probably you are not familiarized in the UK for hepatitis C elimination. There are we have like 23 operational delivery networks. So there are hospitals, outreach services, GPs, peer support, our hepatitis C trust, all of these that have made this success possible. This is just to talk about a little bit about how these delivery networks work. Pharma, charity, drugs and alcohol service, custody centers, mental units, emergency department, all of us working together with the same objective of eliminating hepatitis C. Access to treatment, as I said, from 2015, we can see here the curve of all the patients that have been treated with the new therapies and how this has dropped because we are not diagnosed as much cases as we should be doing. If you have hepatitis C previously and you came in this era with the new treatments, it's more likely that you get cured because the rate of cure was over 95%. What else and what is important to mention is also the integration of these services to social marginalized groups. This was published a couple of years ago. This happened in England, and this is an intensive hepatitis C test and treat that happened in all the prisons in England. And for me, one of the highlights of this project is to recognize that there was a screening over the 90% of all prisoners in 5 days since they incorporate this pilot of this program, and all of the patients that were positive or the prisoners that were positive, they were treating in less than 2 weeks. The majority of them, as we expected, were cured, and this is the way how we could eliminate the hepatitis in an area in which we know that is high prevalent. This is the latest, and that's what I wanted to comment a little bit. Sometimes, as I said, there is still been people who are not aware of this disease. And we have included over the last 2 years something that I would say opportunistic test. Is that opt-out testing in the emergency department, in which we are testing for the blood-borne virus. That means hepatitis B, hepatitis C, and HIV. So everybody who attends the emergency department, they will be tested for this virus. And it's important because in more than 1.6 million of tests, we can see how the acceptances was more than 90%. Here is the majority of cases we will see will be in London, but we were able to diagnose 176 cases of new hepatitis C, or at least people with hepatitis C that hasn't been engaged with the care. So it's important because when we are still applying new diagnose methods, we are still simplifying the diagnosis and the treatment, we know that we will be able to capture the difficult part of the population that is still having the disease. As I said, this is also happening for hepatitis B. So the prevalence of hepatitis B, or the number of cases that we are identifying, is higher than hepatitis C. And that's why I will just say that we have a lot of things to learn from the hepatitis C elimination, and now hopefully to apply for hepatitis B. Important and not the last is said that we haven't been alone. There has been, beyond the state-run public health programs, several civil societies-led initiatives. I want to recognize again Hepatitis C Trust that has allowed this to happen. And with the slogan "They leave no one behind," has been a way how we have been able to test for hepatitis B, hepatitis C, and HIV in another settings, and also to allow some people to request this test online, or just enter to the page and do that self-testing at home. So every strategy, every new initiative has helped to the UK to be one of the leading countries in eliminating hepatitis C. My take-home message about this presentation is the UK remains on the track towards to the WHO target of eliminating hepatitis C by 2030. I think that we have done great. There is a lot of things that we can improve, but we are heading in that direction. However, hepatitis B elimination targets or proper strategy is limited, and that's something that we should need to focus. Expanding the screening and testing is crucial for elimination. We know that almost 80%, 90% of people infected with hepatitis B and hepatitis C remains unaware of this infection. Testing simplification and treatment decentralization could help to eliminate these barriers in the screening and treatment. So people don't need to come to the hospitals. We can go outside, or they can receive like a self-testing or home testings. For me, this is something that we have to recognize. The DAA therapy has transformed the management of hepatitis C, achieving cure in more than 95%. For us in hepatology, this is a true success in our field. Hepatitis C is not as it was 10 years ago. We have seen the decrease in the mortality, decrease in complication, and the hospital admissions related with hepatitis C. Hepatitis B, again, we can suppress the virus. This has been available more than 25 years. However, the full cure remains elusive. So there's still a lot of things to do for hepatitis B. And the last bit, and I think that this is one of the most important, is because achieving elimination will require political will, public awareness, and investment in testing, treatment, and prevention programs. And again, UK is doing great, but I think that there's a lot of things that we can do to improve testing, linkage to care, and that's something that we have to move on to hepatitis B with the experience that we have with hepatitis C. Thank you, and I am happy to answer any question.
Gosh, that was brilliant. If somebody had have told me 25 years ago, when I was hearing from, Professor Foster at the London about what we might be able to do with Hep C, that you were going to have the first line of a take-home message that we may eliminate Hep C by 2030, I would have said it's just pie in the sky. You've touched upon on your slide the what next, but if you want to leave us with a what next, what is your next thing that you will demand either from hepatology or public health or the UK or us? What is that thing that we can take away and do?
I think that, we have a great experience with hepatitis C. I think that we need now to move on with hepatitis B. We need to test. we need to screen more. We have the audience, we have the experience, what we did with hepatitis C. Now we need to focus more on hepatitis B. We're still missing a lot of cases.
Beautiful, beautiful. Well, I will take that very clearly. Thank you very much. And Joe, only in the interest of time, because I know there's a lot of interest, I will perhaps draw the shutters down there, if that's all right with you, Dr. Guerra-Velas.
That's okay.
Well, fantastic. Thank you very much. Well, thank you very much to all the speakers, and thank you much to all you for coming. I want you to consider the speakers here, the oxygen. The meeting is the lungs, and I want us all to be the corpuscles that carry the oxygen we have gathered during this meeting to the organs in our hospitals, to our friends and our medical colleagues, and tell them what we have heard, because it's important. Of course, I want you to bring those colleagues here next time. We're going to post, we have posted the link to the LinkedIn page. We're going to have a simple message. Go to that page. It will have the link to the YouTube video. And if you have things to say, you can, of course, on LinkedIn use comments. If we can't, for the people who asked for emails, we'll try our best to get an individual email out to you. Thank you again. Come again. There were times in this afternoon where I wasn't too sure I was going to get through it, where I wasn't too sure I could continue medicine, but I am absolutely delighted to end the meeting on fantastic news of the harms we have eliminated, the harms we have seen, and the successes we have. And there is somebody with a hand up. So I am going to just see whether that person wants that hand up and whether they've got anything to say. My final word whilst they're thinking is I've got to say thank you to Nella, because she put the whole meeting together. Thank you again, Nella.
Thank you so much, Phil, as well, for chairing the meeting. And thank you, Salma and Kath, and all the fantastic speakers today.